All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's episode is about being dismissed from cases, either by patients or our colleagues, which was discussed in a recent publication in JAMA, which is titled Why Good Palliative Care Clinicians Get Fired. And our guest today is one of the authors of said paper, Dr. Elliot Rabinowitz. Elliot is a pediatric pulmonologist and palliative care physician at Boston Children's Hospital and Dana-Farber Cancer Institute. He's the director of inpatient pulmonary services at BCH, as well as helps direct the pulmonary division's quality improvement and patient safety efforts. His areas of interest lie within the intersection of quality improvement and fostering well-being for individuals with severe chronic respiratory illness and their families. And when not busy with his respective clinical responsibilities, his priorities are spending quality time with his family and somehow manages to continue to get every daycare cold imaginable. Welcome, sir.
Thank you so much for having me, and at this moment, actually healthy, which is much great relief.
Right. So, our format for today, Elliot and I have agreed to a little bit of a discussion around several points, and then we hope to save a few minutes at the end for some questions from our palliative audience. So, we will jump right in. Elliot, I have shared with you that consultation etiquette was the first thing that popped into my mind when I finished reading your paper. And I think about the consultation etiquette of honoring turf. And then, depending upon how savvy we are at navigating those turf disputes, whether primary teams will ever work with our service. Again, I would love to start by getting some of your perspective on how consultation etiquette fits into this concept of being dismissed.
Yeah, I mean, I think um, none of what we're sort of saying here is to sort of put aside that respecting sort of classical rules, quote unquote, around consultation etiquette are important. So, sort of understanding, right, that we are at its core generally consultants in palliative care. We are at the behest of sort of those primary teams, and when they reach out to us and trying to do our due diligence to understand why they're reaching out to us, how they think we can be helpful, acknowledging and sort of thinking in advance, sort of what they're hoping for us to do, and if there's any areas that they're saying maybe don't go there yet, and trying to understand why maybe they're saying that. You know, I think obviously that is on balance with the idea that at its core, and other folks, including Bob Arnold and others, have sort of talked about this in other papers, that, another core role of our job as palliative care clinicians is to sort of advocate for patients and families, and more so not necessarily just what they need, but sort of what is overall deemed to try to lead to what is thought to contribute to best outcomes or goal concordant care, or sort of further the care and the conversation for that patient and their family. And so, certainly at times, sometimes those two things can not be at odds, but sort of be two truths that we try to need to hold at the same time.
Mhm.
And so I think it still is important for us to sort of understand what those classical rules of consultation etiquette are, and know that the only way that we get more consults is by building those relationships with those primary services. And at the same time, sometimes it involves educating those primary teams around, you know, where the patient and family is at, what really would be goal concordant, what are their questions, as well as what can our role be, and what maybe our role ought to be based on sort of what we're learning from those patients and families in our conversations.
Yeah, so funny you brought up Bob Arnold because I have one of his quotes here in front of me,
Mm.
which uses this lovely and statement. So it says here, the real question is how can I be considerate of the attending's perspective and advocate for the patient? I think that has been a major theme in medicine recently. It's the and. How do I be thoughtful about patient autonomy and the morality of the physician and et cetera, et cetera. It's the and.
Yeah, absolutely. I don't think we're going to get very far. And I think we all have probably experienced this at times by trying to take sort of like an oppositional sort
Mhm.
of approach of saying, well, I heard this and I know best. Everybody is coming at this, right? We're all going into each day trying to do the best that we can, trying to navigate incredibly busy and complex systems. no one's coming in trying to say, I'm trying to do the exact opposite of what somebody else is doing here. And so it's it's important for us to sort of acknowledge that and sort of take the time to understand where everybody's coming from and sort of through what lens are they making their recommendations or their statements or whatnot to try to find out where are those areas of agreement to actually push that care forward.
Yeah. I jotted down a note that says, don't go there yet. I want to go there, but I don't want to go there quite yet. We'll circle back to that statement at the end.
Yeah.
So you had three example cases in your paper, and it's being dismissed after assessing a suicidal patient, being dismissed after overstepping, your word, not mine, overstepping the primary team, and then being dismissed for prognostic mixed messages. And I have lived all three of those. But I think it's a but. I struggle to see those three cases the same. And I'm certain that in reality, right, these cases are more nuanced than what you can put in an editorial, but we take them at face value. And to me, it feels like in that very first case, you're being dismissed honorably because you have acted on a moral duty as a physician to do the right thing, and you're expected to do the right thing. So maybe we hear a little bit from you about what are some of the circumstances that you would feel most proud to be fired for, where you think that you are doing the right thing.
Yeah. Yeah, it's a good question. I mean, I think first to name, and I think we highlight in this in the paper, like I'm never necessarily proud for getting fired. I
Mm,
think it is not
mm,
necessarily
mm,
something to be celebrated.
mm-hmm,
And at the same time, it is sometimes unavoidable. And
mm-hmm,
so it's okay to sort of say, this is something that we can sort of take a step back from and sort of learn from. Now, there certainly are times where, fortunately rare, where there are times where it feels like that really is sort of the right thing to do. I think, as I said before, there's oftentimes where we say we have to accept that there are different views, perspectives, lenses through which teams are sort of coming at. And we, I definitely think of my job as just how to try as best as I can. Obviously, have not been successful at this at certain times, but try to put aside my own personal beliefs and sort of understand where patients and families are coming from. Try to sort of navigate the medical information that they are hearing to help sort of move that care forward. I think where the frustration arises, right, is when feeling like you're consulted for that purpose and yet then not being allowed to sort of help facilitate that furthering of the conversation or sort of step forward. And I think if despite all of our core palliative care approaches of working with those primary teams to say, here's what I've learned, here's where my recommendations lie. And if after repeated efforts around that to try to understand why maybe they're not sort of accepting or in agreement with those recommendations, you keep getting push from the patient or family to sort of move things forward. Now, that's one scenario where there's sort of a discrepancy between the primary team
mm-hmm,
and us as the consulting team. I think you're right that each of these cases are certainly nuanced and different in that it's a different experience when getting sort of fired by a patient or a family, and where we may represent something that is particularly sort of difficult for them to confront. And again, that's where it may be somewhat unavoidable even if we approach those conversations with the most sincere, thoughtful approach, there may be their own prior experiences. There may be their own perceived um, sort of assessment of our own values that were sort of impacting what we were saying. They may hear a different sort of prognostic statement from us than somebody on their primary team. And as much as they respect and appreciate that truthfulness, they also may be skeptical or resentful of us sort of trying to help them consider what an alternative sort of prognosis or sort of future may look like for them. Um,
there are certainly things that we cannot control, people's backgrounds, their experiences, how they interpret. I also think time maybe factors into that. Like most of the time, I am trained to meet people where they're at and to assess their readiness. And I think we're pretty good at not overstepping that boundary by for asking a lot of permission. But there are some of those cases where time, we don't have that. We're worried
Yeah.
you are crashing and burning today. You're going to end up in the ICU on event today. And I can still give you some control. I can say, hey, let me give you an hour to think about this, and I can come back, prepare yourself, but we have to address this today.
Yeah. I think that's certainly a huge component where this gets trickier. Like our role gets trickier where we come in sort of and have this ask maybe from the primary team to try to do something that feels really, really hard based on the time that we have or based on the limited amount of time that we have to sort of have established relationship and trust with that patient or their family. Um, Especially if it's late in someone's disease course or there's an urgency around their disease. Especially when so much of our work, right, is about sort of like uncovering fears, exploring worries, trying to help them get to a place of regaining some control, but that's often through a lot of really hard, difficult conversations. So I think you're right. I think all of that plays in.
I appreciate you pointing out that maybe it's not being proud to be fired, but it's a willingness to risk it when it's
Yeah.
important or unavoidable. And so, let me share a case with you of maybe not where I was proud, but willing to risk potentially being fired. So, um, I was consulted by a nurse at some time in the past, and this is a real case, but I'm going to sort of fudge the details for the respect of everybody involved. And of course, it's the nurse who calls because it's the nurse who's the best advocate for the patient in the hospital. And she's calling because she has a patient who's slowly dying in extremis, unable to access hospice enrollment until the following day. And there's a conflict where the surgical team is unwilling to allow the primary team to place comfort orders until hospice enrollment because of concerns about mortality numbers, etc. And so I talked with everybody involved. And yeah, that was the short summary of the situation. And when I went to see this patient, she was in extremis, gasping for breath, family tears, asking, what can we do? And while I was still in the room, I placed the comfort orders. And then I went back to the attending surgeon for the second time that day to explain why I did what I did. And the plot twist, I think, which is so interesting, is it turns out there was really no conflict at all. It was kind of all an illusion of a conflict. So the surgeon had such a reputation for creating fear that no one felt comfortable enough to speak up. And they were working in darkness and they didn't know the patient was suffering. And after I told him why I did what I did, he agreed, thanked me for it, in fact, which kind of goes back to the emphasizing that one of my thoughts about all this is I think often disputes aren't actually involving morality or poor choices about virtue. It's about communication, often, almost always.
Yeah. I think that's right. And I think oftentimes we can see that in settings that are not urgent, where there is not a patient in extremis, that there is a range of ethically, morally, medically acceptable paths. And we may see like there's one in the end that we think we're all likely to get to, but there might be different paths to get there. And so we may feel like there's one that's most goal concordant, but maybe the other primary teams or the oncologist or the cardiologist or pulmonologist who's known that patient for 20 years has a different perspective of which of those paths feels right at this moment based off of their knowledge of that patient and their family. And so that's okay. I think to your point, like there certainly are these cases where we feel like those primary teams, for whatever reason, are there may be some mistaken understanding of really what that next step really ought to be. So there are those individual rare circumstances where we feel like other teams or our colleagues are sort of um, maybe making a mistake and maybe sort of not sort of willing to sort of go there. I think it really has to be when do I, as the palliative care clinician, feel like I push in those moments is really when it has to be such a extreme sort of case where there is that urgency or really at odds for some reason in furthering that goal concordant sort of care. And I think you highlighted, right, even in that preface of where you said, I talked with everyone, I was talking with the family, like everybody was on board except for this one really key group. And then ultimately they were in alignment.
Yeah, they
So I
were.
think you sort of did that due diligence of like, how do I go about this to make sure it's not just me being rogue here?
I'll tell you, I wasn't sure I was going to last the day and still be working, but I am.
Yeah.
So, so the second two cases you had overstepping the primary team, being dismissed for prognostic mixed messages. There's this devil on my shoulder, a voice in the back of my head giving me all these but statements. But did I talk to oncology to make sure I was on the same page? But if I knew there was a discrepancy, or probably a discrepancy, is there a savvier way for me to address that discrepancy, et cetera, et cetera? I'm sure you have heard these too. I would love your wisdom on the doubts playing in my mind about some of this.
Yeah. You know, I wish I had sort of the quote unquote answer here. I mean, I think it goes back a lot to what we talked about before about our cores of palliative care practice as well as balancing that with consultation etiquette. I think we need to be make sure that in those moments we're taking a pause to be sort of diligent about our own best practices, that have we truly sort of assessed patients and families' readiness to address those difficult conversations? Are we respecting turf and sort of trying to take a moment to understand where those primary teams' perspectives are? Are we being responsive to both of those important groups, both patients and families and primary teams? I think we pride ourselves in communication. We think of our specialty as a specialty in learning how to effectively communicate and move difficult conversations along. And so it feels in these moments there's a lot of shame behind it, or sort of feeling like that self-doubt, like you've sort of highlighted, of have I really done this? Am I doing the wrong thing here? I don't think that's wrong to sort of take that moment to check yourself and say, am I not driving this based off of my own ideas of what is right? I am certainly not perfect. I have made these mistakes in the past. And so quote unquote getting fired in these scenarios, it doesn't absolve me from thinking about them. If it's quite the opposite, it sort of requires then that I take a moment to sort of reflect on them and make sure that I did exactly as you highlighted, all of those right things. What else could I have done potentially differently to try to facilitate this alignment across all of these different teams and people that were involved, if the ultimate goal is to further the conversation and advance goal concording care?
I've been working here for about 10 years now, and I know that, say, if an oncologist is involved, I've got all their cell phones, and I have a pretty good sense of what they're thinking even before I read into the case, because each one is their own unique person and they have their own biases and thoughts. And I know them all pretty well now. And I make it a point that I call their cell phone when I think there's any potential for any issue. And I call with humility and I call with curiosity, right?
Yeah.
Because hey, this is Dr. Martin. I'm really worried about X, Y, or Z. And maybe the oncologist moves over a little bit and says, you know what? I'm pretty worried about that too. Or perhaps I learned something new, right? I call and I learn about some marker, something that gives them some hope or some nuance that I didn't appreciate, and I move over a little bit. But either way, we one of us moves or we both move and we find some common ground. I think it's pretty uncommon when you pick up a phone and when you talk to somebody face to face, not secure chat or all that other garbage that's out there nowadays, that you can find some mutual area.
Yeah. And I think that highlights like when there is that tension, that has to be the focus. It can't be sticking firm. You can try to continue to elaborate on what your conversations may have been with the patient and family to sort of highlight. And it's not to go, if a patient and family, you're consulted for symptom management and they start asking questions about what's to come, your job isn't to necessarily just upfront answer those questions, but to sort of bring that back to the primary team and say, hey, I know you wanted us involved for this, but hey, they're also thinking a lot about this. Is that something that you've explored? Or what's been your perspective there? If there's misalignment sort of around that, it's not to sort of say one's right or wrong, but exactly as you highlighted, try to find that common ground. And just as we don't try to force prognostic acceptance to be able to move a conversation forward, it's more just a prognostic awareness. So it's okay to sort of share, and whether or not a patient or the primary team sort of believes it, doesn't mean that we can't find some common ground around, well, what do we do with this information? Maybe it's not focusing on prognosis. Maybe if we don't have to in that moment, it can be having another related part of the conversation to try to move this, as you said, a little bit closer, where okay, what else is really important right now to sort of support quality of life? Or how much is it worth going through to sort of get to that next step in treatment? And sort of some of that may get over time to these conversations around prognosis. Now, sometimes those are the two cases that you highlighted. It's all about sort of challenges around prognosis and how do we communicate that.
Mm-hmm.
I practice in the pediatric space where we're terrible at prognosticating. We have none of the data, that you all have in the adult space. So we're constantly working in that framework of uncertainty and sort of respecting that uncertainty. But, it's that is a challenging tightrope to sort of balance between us as the consulting team navigating this communication between patients and families and their primary teams.
I want to add one more thing. I don't know if you have experienced this, but uh, in addition to trying to reach some prognostic agreement amongst the teams, I have found that sometimes it really matters if I also give the primary team the first opportunity to share it. A handful of times earlier on in my career when I was sort of jumping in and, yeah, wow, we got consensus. I'm going to go share it with the family. I would occasionally hear, why are you telling me this? Why isn't Dr. So and so here? Were they sending you in because they couldn't say this? I don't want to see them again. And I have burned other people's bridges, gotten them fired, not myself, but them. And I think that is an important nuance. It's uncommon, but it happens sometimes.
Yeah, full-heartedly agree with that around how do we sort of support our primary colleagues in being able to do that. But part of that work is then giving them the tools also to be able to do that.
Mhm.
Not everybody's spent years sort of practicing how to give a headline and how to lead a family team meeting or how to navigate in delivering difficult news. And so a lot of it is sort of not only exploring are they willing, but also giving them the tools to be able to actually do that effectively.
Yeah. All right. I've got one more question for you, but I want to let the audience know that we'll open it up for questions after this one. So if you've got something, type it in the chat, raise your hand, find a way to let us know, and we'll field some. So my last one is that our over the last 10 years, I've watched our program grow quite a bit, and the way we can push and challenge professionally other teams
Mhm.
is greater now than it ever used to be because of those relationships. I'd love to hear your journey in all this, how you've grown over time to challenge patients and colleagues, and how it has evolved.
Yeah. Um, it's a great question. I had to sort of reflect a little bit on it. I think there's a few things that come to mind of like in doing this, what what have I learned as far as like being most important, I guess. One is I think in palliative care, we're all trained to sort of build some degree of coping mechanism, hopefully healthy coping mechanisms and sort of resiliency for the work that we do. I think separate from that is making sure that there is a multidisciplinary space to sort of reflect on these hopefully rare circumstances where it has been in huge benefit to not only just for my own coping, but to be able to say somebody else on my team heard how we were doing this, was part of the discussions, could help challenge me to tell me when maybe I was going pushing too hard or pushing too far, where there might be a different way to sort of go about it. I think secondly, simultaneously, especially as a younger career physician, I think it's been instrumental to have leadership that is willing to sort of go to bat for you, that will sort of sit, listen, try to understand why you're doing the things that you're doing, and then sort of when it feels right, sort of be willing to sort of back it up, acknowledging, as we said right at the beginning, one of the fundamental things in consultation etiquette is that you're not going to get more consults if you sort of burn bridges or sort of make these negative relationships. And so having a leader who's willing to sort of back you up when it feels like some of those things are at risk is has been hugely important. I think the last piece for me is I've sort of carried over from my pulmonary practice, which is more so that when I'm working with patients and families and sort of they're either not adherent to sort of what we recommend, I try to own that as much as possible, or I have our team own it as much as possible. As how have we not been clear? What have we not sort of assessed as barriers? What are those social determinants of health that we may be able to modify? And I think translating that into the palliative care space has also been beneficial, both with patients and particularly with colleagues. When we make a recommendation and it doesn't resonate with a colleague,
Mm.
it forces me to say, okay, maybe I need to try to explain this in a different way, or maybe I'm not understanding some prior experience that they've had with us in palliative care that is sort of tainting the way that they're thinking about the recommendation that I'm making. And so trying to take some humility and ownership over that rather than coming at it as, ugh, they just don't respect us or they just don't believe what we're saying.
Mm.
And so I think those are the things that I've like increasingly gained over time to try to maintain myself in this work.
Lovely. I don't see any questions, and I love that because that gives me a chance to circle back to the question of don't go there yet. So we've all heard this. I have absolutely had people tell me you can talk about X, Y, and Z, but you are not going to talk about death, dying, prognosis, et cetera, et cetera, et cetera. What's your that is a lecture in itself, but
Yeah.
any pearls of wisdom?
I think there's two sides to that. I think one is clearly that's coming from there's some anxiety around what we're going to do when we get in the room. And so some of that is educating our colleagues around what a palliative care consult entails and sort of what are some of those questions that we ask and how that information can be helpful. I think oftentimes there's a worry, right, that they worry that there's going to be some prognostic disclosure that we're going to do. And so just naming that up front that like we're not going to disclose any of that. And if they ask us, it's really important information for us to be able to deliver back to you as something. So I think sometimes it's sort of making clear what we do. Um, and depending on the circumstance, sometimes we can respect those boundaries and sort of more so just develop that relationship and then show that we are willing to play in the playground nicely and find ways to be helpful.
Completely agree. When we are embedded in a variety of different teams here, and that doesn't happen when you get embedded after a while, right? There's a mutual trust and understanding. I think a lot of that comes from just fear of the unknown.
Yeah. Yeah.
I agree. There's one question in the chat, so we will end with this, and then we'll send you on your way, Elliot. So this is the start of the academic year for new palliative fellows. In relation to this topic, what would be your key advice to them?
My gosh. You know, it's hard because there's so much advice to give to new palliative care fellows. Some of it is just an openness and willingness to get engrossed in the work and to sort of have all of the experiences and feelings that are going to come with that. And so I think some of this is jumping ahead of that in that so much of it is building that understanding of what palliative subspecialty level palliative care is. How does your local institution where you're training work? What are those relationships that are important? How are you going to build up your coping mechanisms and team of support to be able to debrief these things? How do we debrief in effective ways? Hopefully, giving them the skills so that when there are those circumstances that arise throughout the year where this happens, being vulnerable to share that despite being myself, sort of where I'm at in my career, Abby and Bob being at their end in their career, that this still happens to all of us. And so it's not something just that I remember being a fellow and being super passionate about wanting to go in and do all of this and know that no matter how much experience you have, these circumstances are going to arise. And so trying to give them some of the fundamental skills to sort of how to start to think about it, I think would be the focus.
Lovely. All right, Elliot, we really appreciate your time with us today. This was fabulous.
No, thank you so much for inviting me and for having me.
Absolutely. All right, everybody, have a wonderful weekend.